Thank you a lot, Mark. And thank you, Monique. Thank you, Cécile, Mark, for inviting me today. It's a great pleasure to be here. I'm senior researcher at the Biomaps lab, like Jean-Luc Génisson. So it's located at Orsay in the south of Paris. And this is a biomedical engineering lab. So we are working mostly on imaging, but also on therapeutic ultrasound. And I'm trying to use the different tools we have in the lab, imaging tools like, of course, ultrasound, but also MRI and PET imaging, to improve, to optimize our protocol for therapeutic application. So I'm going to give some examples of what we can do with therapeutic ultrasound. There are many ways to use them, depending on the frequency, depending on the intensity of ultrasound, depending on the amplitude and the length of the wave you are transmitting. And so today they are used for burning, for fragmenting, for drug externalization, stimulating, and many other things. And all those applications are mostly guided by imaging, and that's in this way that the tool we have in the lab are very interesting. So briefly, ultrasound, you know, this is a mechanical wave, and when this mechanical wave propagates into the medium, it has an effect. You will modulate your medium, you will compress and make some expansion of your medium according to the wave that is propagating. So when we are talking about ultrasound, we are talking about frequency above 20 kilohertz. So that's the maximum sound your ear is able to hear. So here, what is ultrasound? It's just a frequency that is above 20 kilohertz. And for therapeutic application, it's quite different from what you are going to use for imaging. So, for example, Jean-Luc showed imaging mostly between 5-15 megahertz. That's the frequencies that are currently used in clinics. Here for therapy, we use very low frequency, much lower frequency. Do you have an idea why or not? Yeah. To increase the penetration, that's the first point. To penetrate some, for example, the skull, that is not possible at high frequency or very, very difficult to do. The other point is that when you decrease the frequency, you're going to increase the focal spot. So the focal spot is interesting in imaging to have the smallest one. Why? Because it depends on the resolution, and you want to, for imaging, you want the best resolution. So you want to increase your frequency to have the best resolution. In therapeutic application, usually you want the wider spot as possible. Why? Because if you have a tumor to treat that is several cubic centimeters, it's going to take hours if you have a very small focal spot to treat this whole tumor. So it's interesting to decrease the frequency to make your beam a little bit wider. Oops, sorry. So when we are talking about therapeutic ultrasound, there are two effects. The first one is the thermal effect. You are propagating an ultrasound wave into a medium. This wave is going to be absorbed by the medium, so it's really depending on the property of your medium. And you know that most of you are physicists, right, or have some good basics in physics. When you transmit an energy into medium, this one will be absorbed and you will have a temperature increase. So that's exactly what's going to happen when you are going to do a thermal ablation. I'm going to talk about that after. Another effect, which is less known, is the mechanical effect. You will induce some cavitation inside your body. So this is an example here. Your therapeutic transducer is right there, and you can see what we call an acoustic fountain on the top of the water level. So this is typically cavitation, and that's exactly what's going on into your body when we applied very high ultrasound. So this is very focused, so no worry. We can classify the therapeutic ultrasound in 4 parts. I told you there is some thermal effect and some mechanical effects. You can separate both by the different ultrasound you are transmitting. If you are transmitting continuous ultrasound wave, it's going to be thermal effect because it takes time to accumulate energy and increase the temperature. If you're transmitting pulsed wave, so few number of cycle, it's going to be more mechanical effect. You can have both, but typically it's really depending on the wavelengths, well, the length of the wave, sorry. Then there are 2 other important parameters, is the intensity, high intensity or low intensity. And if you use very high intensity with very long wave, like continuous wave, you're going to have thermal ablation. If you use high intensity with pulsed ultrasound, you're going to have what we call histotripsy, so that's fragmentation, cavitation and fragmentation. If you're going to use the same thermal effect, well, the same continuous wave, but with a lower pressure, you're going to have a mild hyperthermia. That means you're going to increase the pressure up to 40, 42 degrees Celsius inside your body. It can have very nice application. I'm not going to talk about that today, but if you have any question, I can explain that too. And the one I'm working on is called sonoporation. This is drug delivery. If you use very low intensity with pulse ultrasound, you will have what we call drug extravasation. So the main advantage of therapeutic ultrasound is that it's a non-invasive method. It's very focused, very localized, and it's ionizing. Oh, this one is difficult for me. So just briefly, I give you some example of what you can find in clinics. For example, the ablation of uterine fibromes. There are some ultrasound device guided by MRI that are allowed to burn really the cyst into the uterus. Another example is lithotripsy. Maybe if you have heard about that, you can destroy a kidney stone just by using ultrasound. So no surgery, nothing. You just put your ultrasound probe on the top of the body, and you can focus this ultrasound to destroy by fragmentation the kidney stone. So I'm going to start with thermal ablation. So how we can get this high intensity focused ultrasound? So maybe you will find this term of HIFU in the literature. We can do that by making a very strong focusing of our ultrasound beam. And how we do that? Typically, we will make a specific geometry of our transducer, typically of a concave shape, like a ball or a half ball. And that means that all the beam that are transmitting by the transducer will be really focused at a very, very specific focal point. And this focal point can be very small, about a millimeter diameter. We can do a little bit less, a little bit more, depending on the frequency. But what is really interesting is that this allows to go very deep into the body. That means no ultrasound will be transmitted on the first layer above the skin, and everything will be transmitted exactly at the depth that you need, at the convergence of the beam. So thermal ablation exists for a very long time now. It was discovered about 100 years ago, so it's not really new. But it was applied for the first time in the 1950s for brain and for the treatment of brain tumors. And then you can see many applications that emerged about in the 1980s. Now I think the curve is somewhere like like that today. There are many applications, like for prostate gland, uterus, brain, bone, liver, breast, etc., and different pathology like cancer, neurological disorders, cardiovascular disease, etc. So how does it work? As I said, we are going to focus our ultrasound beam, and this is just basic acoustics, and it's easily defined by a few parameters like what we call the aperture of the probe. That's the size of the probe, if you want. And this is the focal distance. And once you know those parameters, you can easily define the focal spot. That means the area, the volume where the ultrasound will be really effective. So those are few examples you can have with different values that give you an order of the parameters we have. Now, when we are transmitting the ultrasound for thermal application, what is really important, it's the acoustic intensity. This acoustic intensity is mainly dependent on the amplitude of the wave you are going to transmit. So you see this is a square of the amplitude divided by the velocity and the density of the medium in which you are propagating. So you can see two things. It's depending on this amplitude and the medium. This is really important because if you need to transmit high intensity ultrasound, you need to transmit high power. So you need really to design transducers that are able to transmit those power. And this is definitely not possible with an ultrasound scanner. They are not done for a therapeutic application, not for HIFU, of course. So that gives you range of value. So if you're not familiar with ultrasound, it's quite difficult to explain, but this is about 10 times the pressure an ultrasound probe can give. And intensity level, to give you an idea, for imaging, the level must be lower than 720 milliwatt per cubic centimeter, per square centimeter, sorry. Here you see it's much higher. So what is important too, it's the tissue in which you are propagating, because the different tissue we have in the body have different attenuation properties. Soft tissue will not attenuate in the same way than bones, or even you see muscle, liver. They have different properties. That means they will not absorb the ultrasound wave in the same way. So the temperature increase will be different in those tissue. Another thing that is very important is that the ultrasound absorption will depend on the frequency you are using. So if you are using very high frequency, like the frequency for imaging, you will absorb, your tissue will absorb this energy much easier than at low frequency. So it's going to be a problem because I said at the beginning that we are transmitting at very low frequency to improve the penetration. But if you transmit low frequency, you will have less thermal efficiency, in fact. Your tissue will not absorb in the same way. So it's a kind of trade-off. And you can play on the frequency for that. So the heat that you're going to generate is related to the acoustic intensity. You can find here the same equation for acoustic intensity with the square of the pressure and the famous density and velocity into the medium. And there is this coefficient called alpha, which is the absorption depending on the tissue you are focusing on. This temperature can be defined by the heat equation. You have the simplest equation here, but this is something we can define. We can really have an idea about the temperature increase depending on the acoustic parameters we are going to apply on the tissue. So you see here a beam profile. So this is the probe. we are emitting wave at this focal spot, and this is a representation of the acoustic pressure. So you see that if you are, for example, here, in the first centimeter of my brain, nothing is transmitted, or almost nothing is transmitted, and all the pressure is really transmitted at the focal spot. So the only biomechanical effect will be at the focal spot. Nothing will happen in the other in the trajectory, in the beam pathway. So it looks like that when we represent in 3D. And this is an experiment that was performed ex vivo on a liver, and you can clearly see those are the spots where ultrasound were transmitted, and you can clearly see we burn the liver at that spot, so you can clearly observe the change of color. It's just cooked, in fact, by ultrasound. So it's not an efficient way for cooking, but inside the body it works. You can also, if you play on the trajectory, on what we call the delay between different elements, if your transducer has many elements, you can also have something almost continue like that, something homogeneous. And so it's quite interesting to work on the sequence to get this kind of homogeneous ablation. So now, what about imaging in that? For thermal ablation, the most important imaging methods is MR. Why? Because thanks to MR, you can easily know where you are applying your ultrasound. It's for guidance, but not only. During the procedure, you can do real-time MR thermometry to achieve the planned outcome. So that's typically something you have almost in real time, means refresh every 1 or 2 seconds. You can know the increase of temperature thanks to a specific MR sequence. And you know exactly where you are in your cycles. And this is very important because thanks to that, you know exactly when you have to stop your ultrasound beam to decrease the temperature again and to not spend too much time into a spot that is not interesting. Once it's burned, it's burned. You don't have to spend more time. And to define the time you have to spend, there is an equation called the thermal dose that is defined by the temperature you need to rise above 43 degrees Celsius. So above 33 degrees Celsius, your tissue are going to be burned. So slowly, if you are 43 degrees Celsius, for example, it takes more than 4 hours in muscle if you are applying 43 degrees Celsius. But if you are going up to 60, 70, or 80 degrees Celsius, it will take only a few seconds. So that means you have to spend only a few seconds per spot to reach this thermal dose and to burn your tissue. Okay? So MR is also used after the therapy to look at the efficiency of the therapy. So for example, here after gadolinium injection, you can clearly see the area where ultrasound were transmitted. And it corresponds exactly to what you plan. The blue spots are the focal spot where ultrasound were transmitted. And so you can have a validation of what you have done. So now there are many systems existing in the world. This is an example from the society in Cette with the Exablate. So this one is under MR. The patient, you see, has the transducer under her. And this is specifically for uterine fibroid, but you can see other devices that are used also with ultrasound-guided therapy. So this is not MR, not at all. But inside this hole here, you're going to find a therapeutic transducer, the one in orange, and if you look at here, this is a basic imaging probe, ultrasound imaging probe. So in that case, they used ultrasound to guide their thermal ablation. Why? Because they are doing that in soft tissue, and ultrasound imaging is quite good for imaging soft tissue. It's cheaper, it's real time, so there are some advantage of using ultrasound. That's typically what you can see in this image. So they applied ultrasound at the focal here, and you can have a look here. You can clearly see enhancement of the contrast in the ultrasound imaging, and that corresponds to a burning of the tissue. So this is this is a non-exhaustive list of systems that are currently existing and already used in clinics. There are some from very huge company, other one from startup, for example in France, and other from Asia. But there are many devices able now to perform very efficient thermal ablation under MR or under ultrasound imaging. Now the problem comes from the skull. When you want to treat the brain, this is a real problem because the skull, this first function is to stop mechanical waves. So this is a mechanical wave, mechanical stimulation. And of course, my brain is okay. My skull not, but my brain is okay. So ultrasound waves are mechanical waves. So the skull is there to stop ultrasound. So to allow that, they developed different devices, more complex devices, like those helmets at very low frequency. So I don't know if you're able to see the different spots inside the helmets. There are about 512 in that one. I will show you another one with more than 1,000 elements. So those are single elements. Typically, ultrasound probe is 128 to 256 elements. You see here, we are much more elements than for ultrasound imaging. Why? Because we need this to allow focalization, very good focalization inside the brain. And this helmet allows to really focalize in very small spot inside the brain. So this is the one from Insightec. So you see there is a stereotaxic frame, and the patient is going with this under the MR. This is MR compatible. So those therapies are applied now in clinics, and I'm gonna to show you one of the most famous applications, which is for the treatment of essential tremor. So I'm gonna show you an example here for the sound. So you see this patient is shaking a lot. He's not able to put the ball from this box to the other one. That's before the procedure. There are some tests like this one where the patient has to relay the spot from here to here, here to here, or here to here without going outside the lines. So you see he's not able to do that because he's shaking a lot. So this patient is going under MR, and the clinicians are defining the area that they know perfectly that is responsible of the essential tremor. So then the patient is going under the MR, so he's awake, absolutely no anesthesia, no incision, no holes, no electrode, no infection, no blood clots, no brain damage, nothing. Now this is the image after the therapy, so you can see a dark spot here on the MR. That's exactly where they burn the tissue using ultrasound in this famous helmet. And now this is the same example just after the surgery using ultrasound. So you see the patient was able to relay the lines without any problem. this is a video a few months after. This is a single treatment shot. And this happened a few months after, and now he's able to translate the ball without any problem. And I can't tell you this is a few months after because the patient was shaved during the procedure, so no hair, because this is essential for ultrasound coupling. And you can see that it works only after one treatment, and that this treatment was able to be efficient for months and years. Do you have any question about thermal ablation? Yeah? The essential tremor? What's the cause? Oh, I'm not an expert in neuroscience. I know this is a dysfunction of some connection between synapses, and so they have to burn this specific connection to avoid a mistransmission of the signal. But I'm not an expert of this pathology, so that's something you have to confirm. But from what I know, this is the reason. And the patient is clearly okay. We just burn a very small area. The brain is finding other way to work without this misconnection, and it's perfectly okay. For what? Epilepsy? Yes. That's something we do. I will show you at the very end of the lecture another thing we can do for epilepsy. It's called neurostimulation, and it's gonna work. Yeah. You can avoid seizure by doing neurostimulation, or at least reduce a lot the number of seizures. But that's the same for what I will show after BBB opening. It's also helping for epilepsy. I'm gonna talk about that. So now I'm talking about mechanical effects. So if you remember well, mechanical effects, we can obtain them by reducing the pulse length, just transmit very short pulse. Very short pulse, but at a very, very high pressure, much higher than what we are doing for thermal ablation. I'm talking about more than 20 megapascal. That is just huge. And when we do that, we create some bubbles inside the body. You are boiling, in fact, your body, and so you create bubbles inside. And a bubble, if you remember the lecture yesterday, it's a very good contrast agent. It's very sensitive to ultrasound. And the fact is that you're transmitting so much pressure on your bubbles that you are going to fragment your bubbles. And when you're doing bubbles fragmentation, you just destroy everything around. This is typically used for, I don't know, if you have a ring like me, if you are going to the jewelry, you say, okay, I'm going to clean your jewelry. It's going that into ultrasound baths. Maybe some of you have some ultrasound baths in your labs just to clean instrument. This is histotripsy, in fact. It's washing everything. So that's what we are doing in your body. And here we have some example. It's going to be very fast, you see. There are only few microseconds between the beginning of ultrasound and after 130 ultrasound, you see many bubbles, and then kind of very huge bubble because there is some coalescence between the bubbles. I can show you a video to show you how it can be targeted. So that's different pulses that are transmitting at different locations, and you see those bubbles moving. So you can cover a very huge area by doing that. Now what's going on? So the expert on this are the University of Michigan, and typically this happens into your tissue. You make a hole. You destroy everything. So here they used a lever, and they wrote the aim of Michigan into it because they destroy any tissue in this. Now they're doing that. They have done that in large animals and then in clinics. So I can show you an example of what's going on animals. So this is a pig liver, And you will see, so those interference are due to the therapeutic transducer. It's transmitting at 1 megahertz, you are imaging at 3-4 megahertz, so you have some interference. But if you look at this zone, you can see bubbles moving. In fact, they are creating cavitation at this point. So this is just interference, but your focal beam is really here. So we can follow by ultrasound imaging those bubbles moving and destroying the tissue. And once they stop the treatment, you will see at the end of the video, should be soon. I don't know where is the end. Well, at the very end of the video, yeah, now they stop. You see, it's dark. There is no more tissue. It's just a hole. So they are trying now to apply that for clinics and for tumor destruction by using histotripsy. So I told you at the beginning we can use that to destroy kidney stone, to destroy things into the body. Here, this is an application for tumors specifically, and you see they have a therapeutic transducer like that, in which an imaging probe, a basic imaging probe, ultrasound imaging probe is inserted, and so they are able to guide their therapy and to have a therapeutic effect in real time. So another example of histotripsy is what we call sonothrombolysis. So the idea here is to do the same, but in the brain, to destroy any blood clot that can be observed in ischemic stroke. So in that way, the objective is to destroy this clot and restoring the blood flow as soon as possible. So they have done that, of course, in vitro on blood samples, but they also shown a first demonstration on a pig on the femoral vein, and they have shown, so this is basic 2D imaging like Jean-Luc showed, and this is a Doppler, and they shown that before therapy there were absolutely no flow, the flow was completely stopped, and when they applied histotripsy, sonothrombolysis, because that's the term specific for thrombus, the flow was restored just by ultrasound. No surgery, no opening, no medication, just ultrasound. But we can also combine that with some RTPA, so some medication that allows to destroy those clots. And they show that that was also possible to combine the two strategies and to improve the destruction of the clot by combining both. There are some medical devices that are under manufacturing now. This one is from the University of Cambridge, but there are many of them. You see, they are trying to design transducers that are specifically transmitting ultrasound on the major arteries into the brain. You okay? Okay. So now I'm going to talk about drug delivery. So ultrasound are also very used now for drug delivery, and this is one of the most important development in the recent years. So how we do drug delivery with ultrasound? So if you remember well, yesterday you have a nice lecture on contrast agents and microbubbles. So remember, bubbles are highly compressible, so they oscillate under ultrasound pressure. And we are going to use ultrasound with a higher intensity than for imaging. And with this ultrasound, we will try to make those oscillations as big as possible before collapse of the bubble in order to exert a stress, new forces on the vasculature. So typically, we are going to use different kind of bubbles. There are some bubbles, basics like the one Avril showed yesterday, with lipids, gas inside, and we co-administered those bubbles with different drugs that are injecting intravenously. Or you can have what we call smart microbubbles with drug-loaded microbubbles. So the drug can be loaded inside the bubble, and you can use the bubble oscillation to deliver the drug exactly where you want. So now, how it works exactly. So when you apply ultrasound, the bubble oscillates like that. So this is a video that was taken at the University of, at the Erasmus Medical Center, in Rotterdam. It's about 15 million frames per second, so there is no much systems able to do that. But using this frequency, we are able to look at the vibration, the oscillation of our microbubble, which is excited about 1 megahertz. So we have enough temporal resolution to see this observation. So what you have seen is that during the positive pressure, the microbubble is contract, and during the negative pressure of our cycle, the microbubble is expanded. And so when bubbles is doing that, you are doing a kind of cellular massage. That's the real term people used on your cells. So that means you are exerting forces on your cells that's going to modify your membrane, the cell membrane. There is also another phenomenon that is more difficult to observe. It's called microstreaming. You are creating a lot of streaming around your bubbles when you're exciting a bubble. So your bubble is in the flow, in the blood flow, and so you are creating a lot of stress and microstreamings like vortexes around your bubble. So this is really stressful for the bubble, for the cell, sorry. And if you're going to very high pressure, that's the problem, the major problem. I will talk about that a little bit later. You're going to destroy your bubble. And when your bubble is going to destroy, it's going to create shock waves, like Jean-Luc showed yesterday, or microjetting. So this is a collapse of the microbubble in a very single spot, and that can just destroy your cells. You can have very high hemorrhage if you're destroying bubbles like that. And it's going to be difficult for your vessel to be repaired. So this is a brief summary of the different phenomena you have. So this is the cellular massage, and so you see the membrane is moving because of that. This is a collapse of the microbubble, and you create a kind of pore into the cell membrane. And this is a microstreaming, and all these phenomena were observed. So all of them play a role into what we call the sonoporation. So now what's going on the cellular level? So you see here different example of TEM. So this is a basic cell. The basic cell, if we apply just ultrasound, you see it's stressed, and you can clearly see that the shape is different from here to here. It's like me when I shake my joke like this, it's going to be red, and it takes time after that to come to a normal state. Now, if we add some bubbles, so this is a kind of bubbles from Braco, I don't see if all of you are able to observe some holes like that everywhere. So that's what we call the sonoporation. We can see some pore. And inside the spore, the drug is able to go and do what we call transitose. So it's going inside the cell, and you can incorporate your drug inside the cell. So this is for 10 seconds, and 60 seconds we have more holes. Now we wanted to look at if this phenomenon was reversible or not, because it can be a problem. The idea is to inject our drugs, open the cells, then the drug is going inside the cells, and then the cells has to reclose. And that's exactly what we showed here. So we fixed the cell just after experiments, so we see a lot of holes in the first time, and then you see 5 minutes after, 10 minutes after, 15, 30 minutes after, no more holes, but the shape is still different. And 1 hour after, the shell was exactly, membrane, was exactly similar to the first one. So that showed the reversibility of the approach, and that was really nice because we show that we just enhance drug delivery. We don't affect any cells, even the cells that are in good health, thanks to this approach. So this was validated in different models. This one is it's quite old study, one of the first on mice, and they showed they were able to destroy completely the tumor by just applying ultrasound plus the therapy. So you see each arrows correspond to a therapy with ultrasound. So they applied 8 times, and they showed that the tumor was almost disappeared. This is another example in which drugs was paclitaxel, which is a chemotherapeutics, was directly loaded into the microbubbles, and they show in the same way that they were able not to destroy the tumor in that case, because that was a very aggressive tumor, but they were able to reduce considerably the size of the tumor thanks to the combination of ultrasound and drug-loaded microbubble. They have also started some clinical trial, and this is the first clinical trial that was published in 2016. This one was in Norway with 10 patients. And to go fast, because I told you at the beginning that we were not able to use therapeutic ultrasound with a clinical scanner. In fact, this is almost false. In that case, they used a General Electric scanner, and they use contrast agent Sonoview microbubbles that are approved in clinic for imaging, not for therapeutic application. And what they have done here, they just try to apply the most powerful sequence in an ultrasound scanner. Do you have an idea about which sequences? Which one is transmitting the most energy? Maybe Jean-Luc knows. You should. They used Doppler. And they pressed Doppler, 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 Doppler during all the therapy. And what they were able to have an effect on the pancreatic tumor, which is one of the most aggressive tumor, in which they tried to deliver gemcitabine. This is a chemotherapeutic. And they have shown using this non-optimal device, because they are just trying to use ultrasound scanner. Why ultrasound scanner? Because it's easy for clinical trial. They didn't have to develop a new device and get an approval for this new device that takes about 5 to 10 years, costs several millions of euros. They say, no way, we are going to use a clinical ultrasound scanner and go fast. And just by doing that with a non-optimal device, they were able to increase by 2 the survival of people, the half survival of people. So this is very encouraging, and I really think using a device that are really optimized for this application, we can do much more. Yeah.
Increase by a factor of 2 the survival rate.
Yeah. In fact, the median survival, that I was talking about the median survival. You see here, gemcitabine alone, here it's about 9 months, almost. Now if we look at gemcitabine plus ultrasound, they were able to go up to 17, 18 months. So yeah, it's time. It's not perfect. It's only on 10 patients, so it has to be repeated on more patients, but it's very, very promising. Now I'm going to talk about the blood-brain barrier. I'm going to be a bit faster. So as I said before, the problem is when you want to treat the brain. And I don't know if you're familiar with that. The brain is protected by the skull, but also by the blood-brain barrier, which is a physical and biological barrier that will avoid any infection into the brain. So they will stop anything that's in the blood to go outside the blood and to go in the brain. So this is great and a cool barrier when you are okay, when you are healthy. But when you have a problem, a disorder into your brain, and you have to cure this disorder, it will stop almost 98% of molecules, of therapeutic molecules, are not able to go inside the brain. So my colleagues in the US and Toronto, Kuya Voininen, started 20 years ago, more than 20 years ago, working on this application, and he showed that we were able to disrupt the BBB using our microbubbles and ultrasound transiently. So this is really interesting. Just by putting a probe on the skull, there is no need to open the skull or surgery. So there are many applications in which they try different combinations with chemotherapy, targeted delivery, gene delivery, a lot of drugs, a lot of combination. And now we have many labs working on different protocols. So those are the protocols we have in the lab. So we are doing that on rodents, but also on monkey, in which we use the robots to move our ultrasound transducer above the head. Thanks to that, we are able to make whole brain BBB opening or half hemisphere or just targeted BBB opening. That's the same for primate. We are able to do all configuration now. And we used a lot MRI. Why? Because it allows us with gadolinium injection to confirm that we open the BBB. Gadolinium is not able to cross the BBB, so once you inject and you see that, you know that you open the BBB exactly where you want it, so at this focal spot. That's the same when we cover the large volume, like in that case. And we also used MR to be sure that we are not inducing damage. Why? Because I told you if we transmit a pressure that is too high, we are going to destroy our microbubble, make collapse. And this collapse can do inflammation, hemorrhagia. And so we checked every time 24 hours after ultrasound if our animal is well, or in that case you can see a white spot here that corresponds to an edema on our animals. So we used also a lot MRI to optimize our sequence. So for example, here we are doing some square shape with our ultrasound transducer with different pressure. And so we used MRI to confirm that we are able to open the BBB, what is the threshold, the pressure threshold for which we are able to open the BBB. And we also looked at different time to have a kind of kinetics to know how long we are able to inject drugs into our brain efficiently. That's also something we are developing in the lab with PET imaging. So we are working on different protocols with a new tracer that is called FDS, in which we are able to check the integrity of the BBB. And thanks to those protocols, in that one we use T1 mapping. We have some nice lecture on T mapping, MRT mapping the last few days. But thanks to those protocols, we are able to define the kinetics of reclosure of the BBB and have an idea about what time the BBB stay open depending on the ultrasound parameters. So this is very important for our application and for optimization. We also use ultrasound imaging like the one that was presented yesterday, like the super resolution imaging. And for example, here we are able to observe some vasoconstriction that can be induced by the inflammation by ultrasound. We done the same on monkey. So to confirm the targeting, for example, here you have the BBB opening exactly where we target to confirm the safety, but also to quantify using the T1 mapping the enhancement of contrast agent into the brain. But the question now is, do we really need MRI during the procedure? Because if you remember well, I showed you the hexablade system. Okay. We showed that MR was interesting because it allows the thermometry during the protocol. Here we are not doing thermal ablation, we are just opening. So we don't really need to control this thermometry. So now we are working with different people on approach to do this without MR. So of course MR is interesting and CT scan are interesting at the before procedure to know exactly the skull, the property of the skull, the density, the thickness of the skull, and we can do some simulation. Those are now very fast. We can get this in less than 5 minutes. So we know exactly where the ultrasound beam will be when we cross the skull. And then we can use neuronavigation, so very easy systems that allows to localize exactly the probe and the patient under the system. Another way to control during the therapy the cavitation of microbubble is real-time monitoring. So we are listening by putting different ultrasound transducer around the head. They're just listening the signal from microbubble. They're not exciting. The therapeutic transducer is exciting, but those transducers are just listening. And by doing the very famous fast Fourier transform, we are able to check the cavitation regime of microbubble and separate safe regime to dangerous regime. So we have done that many times, and this is typically what we can get in real time. So you can see, for example, appearance of different frequency here on the spectrogram, and this is potentially damage. So to avoid those damage, we used a feedback loop control. So we will going to reduce the pressure in real time. So we are able to do that every 100 microseconds today. So this is really, really fast. And we are able to control and reduce the pressure of this kind of optimized algorithm that allows to excite our bubbles enough, but not too much, to have a safe and efficient BBB opening. So now I told you how to control the pressure. What is important also is to control the localization, and there are some development on what they call passive acoustic mapping. So this is also ultrasound imaging. So we insert an imaging probe inside the therapeutic transducer, and we are able, through the skull, to determine where the ultrasound beam is during this procedure. So this was validated on rodents, on primates, and now it's going to clinical trial at Columbia University, in which they have done some first experiments on in young patients, on kids. So it has been validated on mice, but I'm gonna fast on this. We can also use PET imaging just to quantify the delivery of our drugs. For example, here we use the radiolabeled antibody, and we showed that we were able to deliver this antibody into our tumors thanks to ultrasound. That's this line. And we showed that we improved the median survival of our animal using that. Just to go fast on this, those devices are now in clinical trial for more than 10 years. So there is one, the pioneers are the Cartera device and Insightec for BBB opening, and now there are many, many companies like Navifus, Cordance Medical, or our company Therasonics that are doing BBB opening, but with different approach to perform the efficient BB opening. I'm just going to show you one results on the Cartera device, and then I think I will finish that, no worry. So Cartera is a French company from Professor Alexandre Carpentier, and they used an implant, you see. Alexandre Carpentier is a surgeon, so he's used to open the skull. It's not a problem for him. And so he's putting, when he do the resection, when he removed the tumor, he put this transducer at the place of the skull. And then every month, when the patient comes back for his chemotherapy, he just connects his transducer to the generator, and so he applies ultrasound at the same times. Why he has to do that? Because the glioblastoma is unfortunately, so that's a very aggressive brain tumor, is unfortunately coming back every time. Well, so he has to apply chemotherapy and ultrasound to deliver drugs into the brain. And so you see here, this is what they call the SonoCloud 9. They were able to open the BBB on a large volume, and they showed very nice results. This one is from Nature Communication. It was published last year. They show that they were able to open the BBB and to reduce. So you see, this is the tumor, and they reduce the size of the tumor after many cycles. So it works, and this is very promising. Of course, Scientifique is doing the same. It was another example. And there are many clinical trials. So I've done this review last year in 2023, and there were more than 25 clinical trials, not only for glioblastoma. You see also Alzheimer's disease, amyotrophic lateral sclerosis, or Parkinson. Wow. I'm not going to talk about neurostimulation, but if you have any question about this, I'm going to be pleased to answer. Thank you.